Kia ora, colleagues. I'm delighted to present this research about caring conversations about continence management to enable participation after stroke. I have no conflicts of interest to declare other than the ICS paid my registration for this conference. The old definition of urinary incontinence as a social and hygienic problem was in some ways better than our current definition. The old definition drew attention to what really matters to many of those who live with incontinence after stroke. Participation in meaningful life roles when living with incontinence after stroke is affected by the social stigma of leakage. The lack of adult body control of this important function, the odour, the leakage of fluid beyond the body boundary into a public space, and the dirtiness of incontinence. It is, for those who live with it and their carers, a social and hygienic problem. Our objective in this realist-informed research was to form an explanatory theoretical understanding about the relationships between the context in which continence management is delivered, the mechanisms through which continence management interventions are intended to work for people following stroke, and participation in meaningful life roles inside and outside the home as an outcome of continence management support. In the interview phase of this research, we focused on eliciting information about the links between the person's context and the mechanisms that appeared to contribute or not to successful negotiation of incontinence to enable social participation. These interview data, in the end, formed the bulk of the data supporting our explanatory theory because the existing research was remarkably silent about how people with stroke and incontinence can participate in a socially meaningful way. In all phases of the research, the analysis focused on coding data into these four categories, and in particular on the links between the data in these four categories. One way of expressing these links is in something called a context mechanism outcome configuration. CMOs are an analytic tool in realist approaches, proposing then testing links in the data. It's an iterative process to develop that explanatory theory. So let me give you an example of how we might code data. The leakage was a shock. This woman's body function changed post-stroke. This is context. A referral was made and continence services visited her for assessment and to support self-management. That's a resource or an intervention. More than one option for containment was offered, and this woman has worked out through trial and error which works best to enable toileting and increase her confidence. She can do this on her own. The development of confidence and mastery is a mechanism. She now feels more like the adult she expects to be. After all, toileting alone and in a private place is what adults usually do. She feels more able to take part in events outside her home, so participation is the outcome. Here we can see the link between experiencing the changed bladder function, how the new knowledge offered by continence services is applied to adapt to that change in body, and then to develop efficacy for toileting independence and achieving social continence inside and outside the home. I've divided the figure, which is published in the abstract, into four parts. First, context. The most important message here is that context is not static. It changes day to day, during a day even, over a week, and certainly over time. Because context changes, the person and carer need options, so they have a toolkit of resources that they can apply flexibly and with confidence to participate across different settings. Follow-up conversations are another key resource that enables reflection on the trial and error learning across those different contexts and over time. And this all works to enable effective continence management and participation because the patient and the carer are involved in shared decision-making with the healthcare professionals, and they have co-created the knowledge. They own it about what works, when and where, so that they have belief and mastery in continence management that then enables their participation. Why are caring conversations so important? Because social isolation is one of the worst outcomes of incontinence after stroke. Starting a caring conversation about a taboo topic means the stroke survivor knows they're not alone. Who can begin the conversation? Well, to be implementable theory, this cannot be the sole province of continence specialists. Therefore, our role is to initiate engagement with colleagues in stroke care to increase their confidence to start the conversation. Our function is to persuade, encourage, train and inform our colleagues, all the while remembering they may feel stigma and embarrassment that we have long ago overcome. Acknowledge it and help them do it anyway. What can they do to start the conversation? It's pretty simple. I notice you've got some bladder leakage. How do you feel about that? However, our colleagues won't ask even simple questions like that if they aren't confident about what happens next. Again, it's our role to create and communicate straightforward pathways to more help for them and for patients, giving our colleagues confidence that the conversation they begin has somewhere to go when they need that. When and where does this conversation begin? Well, once the immediate acute care is complete and the person is medically stable is the time to start. It's very easy for incontinence to get lost in a wealth of other problems like talking and walking that are so noticeable. But not being able to walk and talk also contributes to incontinence, and so incontinence needs equal attention. Then, again, at times of transition, because returning home, for instance, is when many difficulties in real life start to appear. And keep going over time. At follow-up with physicians, nurses and therapists. This is an ongoing conversation because context is not static and what works changes accordingly. Why focus on caring conversations to support continence management? It's because it seems this is the core resource that can trigger a cascade of actions and mechanisms to achieve participation in a fulfilling life after stroke while living with incontinence. Thank you for your attention.